Hello, everybody. We start today our review anatomy physiology. We will start with the blood vessels and blood circulation. Welcome, everybody, again. Okay, so here we have the review of blood vessels and blood circulation. What we need to remember and remark very much are the five types of blood cells: the arteries, arterioles, capillaries, venules, and veins. So arteries become, when they go distally, they will be more narrow and narrow, turn into arterioles and then capillaries. Then venules start to come together and form the veins. What is important about these are the capillaries. The concept is the capillaries, number one, they have only one layer, the endothelium, only one layer, and they have openings in the capillaries, not in the arterioles, not in the arteries, not in the venules, not in the veins. It's here in the capillaries where the gas exchange is going to happen. Here in the capillaries is where the nutrients and oxygen are going to pass from the circulatory system to the tissue. Now, we have blood circuits. We have the pulmonary circuit and the systemic circuit. The systemic circuit, let's start with the systemic circuit, is the longest circuit that starts from the left ventricle. So please, left ventricle start the systemic circuit, and then they go to the aorta, then go to the body. It's going to return to the IVC and ends into the right atrium. The right atrium. So what is the beginning of the systemic circuit? Is the left ventricle. And the end of the systemic circuit will be the right atrium. The pulmonary circuit or minor circuit will start in the left ventricle, right ventricle, and ends into the left atrium. Okay, so that is the pathway. So right ventricle, pulmonary artery, the lungs, the pulmonary veins, and the left atrium. So just remember the mnemonic that RBs go to, let's go to LA. So that is about these two topics. All right, so we have, talking about vessels, we have the arteries, we have the veins, and we have the lymphatics. They're going to have three tunics, all of them: inner, middle, and outer. The inner is endothelium, the middle is a smooth muscle, and here is the difference. A smooth muscle will be in the artery, vein, and lymphatic vessel. It's more thicker in the artery and is more thinner in the lymphatic and the vein. The outer is common for everybody. Okay, so the outer or adventitia will be around the artery, lymphatics, and veins. The other difference that we have between arteries and veins are going to be the valves. Valves are founded in the veins and in the lymphatic vessels. The arteries do not have valves. So this is a review. So that's why I'm just mentioning this. The part of the aorta. The part of the aorta will be the ascending aorta. Some books consider the root of the aorta, but in this course and the book, we will talk about as the ascending aorta, as the beginning of the aorta. This is aorta coming, of course, from the left ventricle. They go to the arch of the aorta. So this area is arch of the aorta, and then go to the descending aorta. So this is important because there is a lot of pathology we will see here related to atherosclerosis. So you need to remember that the basic thing of the anatomy of the aorta. Please, again, review here. We have the first branch. What is the first branch appear in the aorta? The coronary arteries, right and left coronary arteries. That is the beginning. Then it's going to go the first greater artery that appears over the arch of the aorta will be the brachiocephalic artery. Brachiocephalic artery, we have divided into the right common carotid artery and the right subclavian artery. And the rest, the left carotid artery, directly from the arch of the aorta, and the left subclavian artery. So left, left, right, left, right. So we have right subclavian, left subclavian, right common carotid artery, left common carotid artery. The difference is that the right and the left and the right common carotid artery and the right subclavian start from a common branch called the brachiocephalic artery. So how many brachiocephalic artery we have? We have two. Okay, so after this, they will go all the way. So all this is the descending aorta. Descending aorta. We have this portion is the diaphragm, dividing the thorax versus the abdomen. We have the descending aorta is all this, descending, 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 descending. But because it's above the diaphragm, this is called the descending thoracic aorta. And this is the descending abdominal aorta under the diaphragm. Okay, so here we have, if you see here, below the diaphragm, here is going to start one vessel, where is the pointing the arrow, and this is the first branch of the abdominal aorta. Can you see here, if you see the previous here is the bifurcation of the aorta. This is the common iliac arteries. And in this graphic, we have this one, the bifurcation of the aorta, right and left. Here is the descending aorta. The first branch of the descending abdominal aorta is the celiac trunk. So we need to remark only this, the celiac trunk, the celiac trunk. The celiac trunk, then we have the superior mesenteric artery and the inferior mesenteric artery. So three main branches, celiac, superior mesenteric artery. If you see here, anatomical position, they go to the right side of the intestines. So all this is going to give blood supply to the right side of the intestines, and the inferior to the left side of the intestines. So we have here celiac trunk, SMA, IMA. At the level of the SMA, we have branching laterally two big arteries are the renal arteries. Okay, so conclusion about this is, if you remember the right hypochondrium containing the liver, the epigastrium containing the stomach, and the left hypochondrium having the spleen, so you will see that the first row of the 9 regions of the abdomen will be giving blood supply by the celiac trunk. Celiac trunk, they have 3 branches that really we don't want to remember those: stomach, spleen, and liver. So that's what is easy to remember, right? So right hypochondrium, liver. Who giving blood supply? The celiac trunk. Epigastrium, the stomach. Who is giving blood supply? The celiac trunk. The spleen, on the left hypochondrium, who give blood supply, the celiac trunk. So the celiac trunk is going to give the first row of the 9 regions of the abdomen. Superior mesenteric, everything that is on the right side, and the inferior mesenteric, everything that is on the left side. Okay, so here's actually a close-up. All right, so we have, after the bifurcation, we have the internal iliac arteries. Internal iliac arteries are, if you can observe very clear here, they are going to be dividing into branches. So we have the right common iliac artery. They will divide into external iliac artery here, from where is my arrow here up to here, and the internal iliac artery. So those are the main branches. So here, the internal, this is the internal branch, will give blood supply to the pelvic organs. Everything that's in the pelvis. Look at the picture. They go to the pelvis. And the external iliac artery will go to the lower extremity. The external is going to go as a transition through the passing the groin area, and this is going to make change name into the femoral artery. This is the femoral artery that is going to divide later in another branches that we will see now. So here we have, again, the aorta, the bifurcation, the common iliac artery, We have the internal here that give blood supply to the pelvic bones, pelvic area, organs, uterus, urinary bladder, prostate, etc. External iliac artery that is divided here, 1 and 2, 1 and 2 divided. Is going to pass the groin, change name again. It's going to change name. This name is called the common femoral artery. The common femoral artery go all the way to the thigh. At the level of the knee, they are going to change name called the popliteal artery. The popliteal artery passing the knee will divide in two branches. We have the anterior tibial artery to the tibia. Here we have the posterior tibial artery. So we have posterior and anterior. Posterior and anterior. This anterior is remarkable, the dorsalis pedis. Here is the dorsalis pedis. Here is the area where you're going to put your finger in order to take the pulse. Take the pulse by palpation in the foot. So here we have anterior and posterior tibial artery, and in the middle we have the peroneal artery. Just remember the tibia and the peroneum or fibula. Fibula or peroneum is the same. So fibular artery or peroneal artery. So this is the branch. So we have anterior, posterior tibial artery and the fibular or peroneal artery. Okay. So then we have the carotid arteries. If you remember here in this cartoon, we have the brachiocephalic trunk in red. Here we have the common carotid artery, the other common carotid artery, the difference between the right and left, you know already that, subclavians. And let's talk about the common carotid artery. The common carotid artery, they are going to give two branches. It's common. Common to what? To two branches. The internal and external. The external, if you see, go to the face, The internal is going to go deeply around the vertebrae and then going to go up even passing the cranium going to the brain. So is the internal carotid artery who is giving blood supply to the brain. Okay, so is the internal carotid artery. Okay. All right. So then we will see here. Here we have the branches that we was talking about. The right and left common carotid. So you're going to check the carotid pulse. If you see the carotid pulse, is if you put your fingers right now over the thyroid cartilage, that is the Adam's apple, side by side with two fingers, you will actually just not move and you start to palp the pulse. So what you are checking is this one, the common and the common right and left common carotid artery. Okay, so here we have the subclavian artery, and the subclavian artery will travel. This is the subclavian artery, right subclavian artery and left subclavian artery. Subclavian, because below the clavicle, go towards the upper extremity. They go under the clavicle. This is the clavicle, and they go under, and they are going to go giving blood supply to the upper extremity. We have different relationships. That is not the purpose of this review. We will have the subclavian artery, then we have the axillary artery, then and then it's going to turn into the brachial artery. So we have subclavian, we have axillary, because this is the armpit area, the axillary, and then they go to the brachial artery. Again, here we have the brachial artery. The brachial artery go all on the side of the arm, below the line of the biceps. Then at the level of the elbow, they will be divided into radial and ulnar. So remember your anatomical position. Anatomical position, the ulnar is under, right? So this under, that means that is, if you elevate your arms a little bit, under ulnar, that is the ulnar, the location of the ulnar artery. All right, so let's keep going. Okay, so here we are going to see, if you notice here, we have a very important correlation here. Just a moment. Okay, so here we have important here. So please, this is what is going to form the circle of Willis. The circle of Willis. Here we have the circle of Willis. Here, if you see here, we have the this is the subclavian artery, and the subclavian artery is going to give here. This area is the one of the first branches of the subclavian artery is the vertebral artery. The vertebral artery is going to go all the way up, and they are going to join with the internal carotid artery here. And here, the internal carotid artery is where they're going to form the circle of Willis. The circle of Willis. Okay, so let's see if I can erase. No, I don't. I'm not going to use it. This. Okay, so here we see. Just a moment. I cannot erase this. Okay. Okay, so here we have here the internal carotid artery. So this is common carotid artery. This is the internal. Follow my finger, my arrow. Common carotid artery. Then it's going to be the internal carotid artery. Internal carotid artery, and they go all the way here. Same here. We have this is the common carotid artery, and here we have the internal carotid artery going all the way here up to here. Then we have the vertebral artery coming from the subclavian artery that is going to give all the communication. So internal and vertebral artery is going to form a polygon here, like a circle. That is the circle of Willis. Okay, so here's again. The concept that I want you to know for veins and arteries is, first of all, veins, we have superficial and deep vein system. All the superficial vein system go to the deep vein system. It's like you are making a glass of water on the table, put a glass of, so the water go by gravity down, right? So always go from superficial to deep. So that is it's like to remember only where it's going to drain the venous return, For this, we need to remember the cephalic vein, very important for catheterism, and the basilic. The basilic, if you put your arms in an anatomical position, elevate a little bit lateral in abduction, you will see that the base is going to be the basilic vein. But remember, the basilic vein is coming all the way. Let me see if I have it here. No, the cephalic vein is going to go all the way. For example, here, this is a cephalic vein. Cephalic vein go down to the forearm. So the forearm is coming all the way here. Cephalic vein, cephalic vein, cephalic vein, cephalic vein, and cephalic vein. And here we have the pinky finger, that is finger number 5, are going to start here, the basilic, all the way up. Now there is a shortcut in between the cephalic and the basilic. That is the median cubital vein. Median cubital vein. That is where mostly the draw of blood drought is coming from. All right, so here just to illustrate, we have the superficial and the deep. So superficial mostly of the upper and lower extremities will be about 1 centimeter below the skin, and the deep veins is not seen, is not visualized, is going to be between muscles and bones. So what we need to remember is the superficial veins of the lower extremities. We have the great and the small saphenous vein. Saphenous vein. Saphenous vein. All right, so that is about. Here we have the venous return in the at the level of the superior vena cava. This is the superior vena cava. Superior vena cava, is going to receive the two brachiocephalic veins. So we remember we have one brachiocephalic artery. Now we have two brachiocephalic veins. These brachiocephalic veins are, the blood is going in this direction, are going to receive blood from the internal jugular vein coming from the collection of the blood from the brain, from the head, and the subclavian vein. So subclavian vein and jugular vein coming together, forming the brachiocephalic vein. Two brachiocephalic veins form the superior vena cava that ends into the right atrium. All right, so let's keep going. Here we have the portal vein. Look at this portal vein, please. This is the venous return. So here's, first of all, what I want you to focus on. This is very important and relevant for when you're going to talk about other pathologies, some pathologies. This is blue behind, that is the IVC. The IVC. In the IVC, inferior vena cava, that is going to drain into the right atrium, correct? Okay. So after the blood with the aorta and the colector, superior mesenteric artery, etc., are going to give blood supply, the venous return is going to happen. They are going to start coming back to the heart. In the GI tract, we have the superior mesenteric artery. So this is the superior mesenteric vein on the right side of the intestine. And here we have the inferior mesenteric vein on the left side. Why is left side? Here we have the descending colon and we have the sigmoid colon, right? So all the blood is coming this way, all the way coming up, coming up, coming up. This is going to receive again the veins from blood supply from the spleen. They are going to receive the venous return from the spleen. Can you see this arrow? 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 All right, so that is going to turn the stomach tube, the pancreas tube. All of these are going to drain together into what we call the portal vein. The portal vein, the portal vein. This is the portal vein. The portal vein enters into the liver and will release what we are absorbing here, nutrients, right? Nutrients here from the intestine. The small intestine, this is the small intestine, and they are going to receive all the nutrients and going to the portal vein. The big factory, 510 functions of the liver, will take all the nutrients and make any of the products that we know, especially proteins, right? Okay, once the portal vein, this is the portal vein, this is the portal vein start to make branches. The blood is going in this direction, again, in this direction, right? So many branches, and they end in the tissue. So that is the end of the portal vein branches. Many branches. After this, the blood is going to start being collected again from what we call the hepatic veins. Hepatic veins. We have the right, the middle, and the left hepatic vein, just hepatic veins. So this blood is going this way, this way, this way, this way. And these collecting blood from the liver are going to drain into the IVC. So now let's see what happened here. Look at this. What happened if you have cirrhosis? If you have cirrhosis, the blood is trying to get into the liver, correct? And that is not going to be able because the liver is shrink. It's going to be very small. So all the blood that was coming from the esophagus, from the stomach, from the spleen, from the pancreas, intestines, cannot pass through the portal vein to reach the liver. So that is going to make the blood go backwards because the portal vein, listen, do not have valves, right? And the portal system do not have valves, so the blood can go in either direction. So in this case, the liver shrink, the blood cannot pass, the blood go back. And these vessels are start to dilate, all to dilate. These dilate so much because these vessels are not prepared to receive that amount of blood, they burst and start to have bleeding, cirrhosis. Okay, so let's keep going. So cardiac output, please, this is really relevant. This is high yield. This is high yield. Blood pressure is peripheral resistance times, we say times, cardiac output. Blood pressure, cardiac output. What is cardiac output? Cardiac output, just listen to the name. Cardiac. Cardiac is heart. Output. What is output? Something that is coming out from the heart. What can come out from the heart? Blood, correct? So that is the how much blood is coming out from the heart in certain time. So listen, cardiac output is how much blood is coming out from the heart in 1 minute. That is cardiac output. What is cardiac output? Is the amount of blood coming out in 1 minute. The amount of blood that the heart is going to eject in 1 minute. Count 60 seconds. How much in 1 minute, how much blood your heart is pumping out? That is cardiac output. And how much is that? 4 to 5 liters. So all the volume of your blood is going to be moved in 1 minute. In 1 minute. So this is important because there's a lot of implications that you will see in the future, near future, about this formula. Cardiac output, so is the volume, stroke volume, that means is the volume that is ejected in certain time. That's why we are going to multiply by the heart rate or frequency of the heart rate, right? Of the heart contraction. So cardiac output is heart rate multiply or times the stroke volume. If you know this, you will save a lot of, I would say, headaches, okay? Here in the exam and in the future. So here we have cardiac output is frequency by stroke volume. So if you have more volume, you have more cardiac output. If you have more cardiac output, you have more blood pressure. If you have less stroke volume, it means less volume of blood, you have, for example, you're losing blood. You have bleeding, hemorrhage. So you don't have enough volume go down. So cardiac output go down and blood pressure go down. That is hypotension. Now, frequency. If your heart rate go up, for example, you release adrenaline. You're scared, afraid, or anger, and your heart starts to beat faster, correct? So what happens with your blood pressure? You're going to have more blood pressure, right? You know that. Everybody knows that. And here we have that the frequency go up, cardiac output go up, and the blood pressure go up. Peripheral resistance. We have the vasoconstriction, that is the sympathetic, and the vasodilation. Vasoconstriction, try to blow air in a very thin straw, very thin straw. How difficult is going to be the air passing through that very tiny straw, right? It's the same with the blood. The blood, when they find an artery that is very vasoconstricted, very narrow lumen, the blood flow is more difficult, means more resistance, more peripheral resistance. So vasoconstriction increase the peripheral resistance. And the vasodilation is going to be more wider. Try to blow air in the very wide lumen of the straw. It's easier, right? So there's less resistance. So vasodilation decrease the resistance, decrease the peripheral resistance. So vasoconstriction produce increase of the peripheral resistance, increase of the blood pressure. Vasodilation is going to decrease the peripheral resistance and will decrease the blood pressure. Okay, so that is the minimum that we need to remember for anatomy physiology, because for other courses we are going to go all the way down to this area. But at this moment we start doing this, and you must don't know this. Okay. All right. So let's keep going. Systolic pressure is normal is 120/80. So don't say 12/8. That doesn't mean anything. Okay. So you need to say the whole number. 120 millimeters of mercury over 80 millimeters of mercury. So that is the normal range. You will see the pre-hypertension, the hypertension stage 1 and stage 2 is coming for later, but you must know this as a basic thing. All right, so here we have aneurysm. Aneurysm, can you see this? Can you see the abdominal aorta? It's dilated here, right? If you see, look at your pinky finger. So that is about the size of the aorta in your body. Yeah, believe it or not. 3 centimeters is already dilated. That is aneurysm. What happened? This mostly happen in arteries who are suffering from atherosclerosis. Atherosclerosis means deposits of cholesterol in the vessels, and that is going to lead into the weakening of the wall of the vessel. So we have pressure inside of the blood making a pressure, so that distend the aorta, producing this dilation. In severe cases, they can produce a rupture, and the rupture of the aneurysm, aorta, AAA, we call AAA, AAA, abdominal aorta aneurysm, that can be ruptured. We have 50% die on the spot, the remaining 50% die in the ambulance, and the remaining 50% die in the operation room. So it's high mortality, high mortality. All right, so let's keep going. Let's go to the respiratory system. And for the respiratory system, what I want just is to review the phases of the respiration. Pulmonary ventilation is the environment and the alveoli, between out, that is the environment, and the alveoli. External gas exchange, please be careful with this. External gas exchange between the alveoli and the blood. The external is not from outside to the lungs, no. External is alveoli and blood. Internal is between the blood and the cells. Okay? Pulmonary ventilation is environment and the alveoli. So from environment to the alveoli. External from the alveoli to the blood, and internal from the blood to the cell. All right, so we already mentioned that. Please, extremely important, three stars here. Inhalation is an active phase. It's important to know inhalation or inspiration. The most important muscle is the diaphragm, period. The exhalation or expiration is the most important is the intercostal muscle, So please just pay attention on that, okay? All right, so let's keep going. This is the external and the internal exchange of gases. Here we have the division of the upper and the lower respiratory tract, extremely important. So look at this. Upper respiratory tract is the nasopharynx, the oropharynx, and the laryngopharynx. So all this is pharynx. All this is pharynx. The trachea is not. This is actually the esophagus. So can you see anteriorly we have the trachea, respiratory system, and posterior we have the esophagus. Here is the larynx. So the upper respiratory tract is going to go from the nasopharynx and including the whole larynx. Below the larynx starts the trachea, and the trachea to the alveoli will be the lower respiratory tract. All right, so that is some definitions that we need to remember. The nasal cavity, we have the nostril. This is the nostril, that openings, the nasal septum. The nasal septum, when you have some rhinoplasty means aesthetic surgery. What they mostly do is to remodel the cartilage. So the tip of the nose is not a bone. So you touch your nose, it's not a bone. The tip is actually flexible. Why is flexible? Because that is cartilage. The tip of the nose is cartilage. So they can be molded, cut it like a paper, probably, like something similar, and they are going to change the shape of your nose. Behind that, we have bones already. How many bones we have in the cranium, in the facial bones? We have 14 facial bones. 14 facial bones. And we have how many cranial bones? We have 8 cranial bones. So here we have remember here we have the olfactory bulb, that is the cranial nerve number 1, coming from the brain stem. Okay, and this guy So, well, sorry, it's coming from the cerebrum, not directly from the brainstem, coming from the cerebrum. The majority of cranial nerves coming from the brainstem. In this case, the olfactory is coming from part of the frontal bone uh, uh, in the middle on the frontal bone inferiorly. All right, so here we have the nasal cavity. So please, when you're going to put a nasogastric tube, you have you tend to put it like this, up. So where are you going? Nowhere. So we need to put it horizontally. Why? Because that is the pathway they're going to go down to the GI tract. All right, so just to remember here, the mucous membranes, we have this is the pseudostratified, can you see very nice pseudostratified epithelium. We have the goblet cells that produce mucus. These mucus are covering all the cells. Here we have a cilia. It's like literally like a broom. You see these guys here, bacteria and virus, they are going to just be trapped in the mucus, and the cilia is going to trap in the mucus means that the bacteria and virus cannot invade our body easier. And we have this cilia that is having movements that get rid to the outside of the getting rid of the bacteria going outside of the nasal cavity. So that is the action what is going to happen. Here we have the mucus. Look at this mucus. So mucus here. These guys, these dots are the bacteria. So the bacteria and virus are trapped in the mucus, and the cilia of the pseudostratified cells are going to move the mucus out, and that's what you are going to protect yourself against dust, virus, bacteria. All right, so here we have the sinuses. Sinuses, going to the point, here we have one pair, two pairs, three pairs, four pairs. So we have the maxillary sinus, that is the largest sinus. Open eyes, open ears here. Is the maxillary sinus is the largest sinus. All of them were going to drain. They are going to drain into the nasopharynx. So these have a channel who is going to drain into the nasopharynx. These guys are going to help for the resonance of your voice. So you cannot hear me very well now because I'm closing all my sinuses. But if I open my sinuses, you're going to have the resonance of your voice. There's a change on the voice. And what they are doing is decrease the weight because it's a cavity. They are going to decrease the weight of the skull. Okay, so here's anterior posterior. We have the sagittal view. Here we have the frontal. We have the maxillary sinus. We have the ethmoidal sinus, the right and left. And in sagittal, we can see posteriorly the two sphenoidal sinuses, right and left too. Here we have the largest maxillary. So can you see the maxillary sinus, the largest, right? Okay. Here we have, look at this nice view. This is the maxillary sinus. So this is the nose, maxillary sinus. Look at this. They are going to drain where? In the nasopharynx. All of them drain in the nasopharynx. So when you have pain localized in these areas, you touch, put your finger here, pain, okay? That probably could be a sinusitis, inflammation of the sinus. Why? Because some cold or some inflammation are going to block the exit of the communication. So fluid accumulate here, fluid accumulated are going to start increase, having the risk for infections. Okay. Just a moment. Sorry, I have some problem with my computer. Okay, sounds good. Okay, so here we have this is an endoscopy, and actually the video was trying to explore what you see inside. So they are going to explore, look at this, how they put they don't put it up, right? So this is going to explore the nasopharynx. So what you see here is the mucus covering the nasopharynx. All right, so I'm going to just pass this. Look at this, please. This is the frontal sinus draining into the nasopharynx. We have the ethmoidal, sphenoidal sinus draining into the nasopharynx. We have the eustachian tube that is draining. Eustachian tube coming from the middle ear is going to drain into the nasopharynx. Here we have the sphenoidal sinus draining into the nasopharynx, and here we have the lacrimal canal. So can you see how many things drain into the nasopharynx? If you cry, you're going to have some tears coming into your nose. So that's why you use paper, right? In order to clean your nose, because the tears are going to go into the nasal cavity. All right, so here we have, this is the lacrimal gland. So the lacrimal gland, so are not here, it's not here. Are here, is here on the upper outer quadrant of the eye. So that is where the lacrimal gland is, and they are going to produce tears, and this is the exit, that is the lacrimal canal, who is coming out and drain into the nasopharynx. Okay, so more clear here. Here we see in the arrow the lacrimal gland. They are going to drain into the lacrimal, this is a lacrimal sac, lacrimal canal, and they go to the, can you see this drop of tears into the nose? Okay, so that is the, here we have more paranasal, so sinus or paranasal sinuses, that is what it's called, okay? Okay, so we already talked about the larynx. So the larynx is going to contain the vocal cords, right? This is not the larynx, this is different thing, it's a bone. Here's the thyroid gland, is the Adam's apple. Inside what we have the vocal cords, vocal cords. They are going to contain who? The epiglottis, epiglottis. Epiglottis is cartilage. And the glottis is the space when the epiglottis is open. So glottis is space, nothing else. It's not cartilage, it's not bone. And we have the epiglottis, that epiglottis, yes, is cartilage. That is going to close the entry of food into the respiratory tract. All right, so we have the vocal cords. These are vibrating. So this is the coming from the trachea. This is the larynx. Can you see the cartilage? These vocal cords are going to vibrate, making the sound of the voice. The glottis is a space. Can you see this black area is a space? This is the vocal cords. And here we have very nice, very picture on this. We can have it. Here we have, this is the tongue. Here is the larynx. Here is the epiglottis. Here is the respiratory tract, and here is the what? The esophagus. This round stuff is the what? The food, the bolus. So when you swallow, you make the food going this way. Oh, sorry, too fast. This way, this way. So at the time they come in this way, you swallow, the epiglottis is going to close the larynx and prevent the food going into the respiratory tract. Okay. All right. So we have the epiglottis again. So look at this. This is the respiratory tract. All this what I mentioned here, and here posteriorly is the esophagus. Esophagus and the respiratory tract. So you swallow. Can you see this yellow? This food. And they are going to close the respiratory. So epiglottis, this space open is the glottis. But this cartilage is the epiglottis. All right, so let's keep going. So this is the epiglottis. Okay, it's not a video, so you don't see that closing. We have the trachea. We have the carina. Carina is the bifurcation. So you see here the right and left bronchi. So you remember the distribution of the right and left. The right is going to be shorter, more vertical, more wider, and the left is going to be longer, thinner, and more oblique. So that is the bronchi. All right, so let's start. The hilum. What is hilum? Hilum is, if you see here, this is the trachea, this is the bronchi. The bronchi is going to enter into the lungs. So that entry into the lungs, that area is going to be the hilum. But it's not only for the bronchi. Bronchi with I is plural. Bronchus is singular. So when the bronchi is going to enter through the hilum, it's not going to be only that. It's going to enter arteries and veins. Which arteries and veins? Look at this, the pulmonary artery. The pulmonary artery coming from the right ventricle is going to divide and go to the right and the left and right lung. And when they make the gas exchange, they're coming back through the pulmonary veins, coming back. So they are going out from the hilum. And the pulmonary veins, we already know that are going to the left atrium. So this is a hilum. So here we have in red arteries, in blue, this is the pulmonary artery, this is the pulmonary veins, and this is the bronchi. So that is, if you cut here, you see the entry of the vessels into the lung. All this is the lung. That is the hilum. Hilum is the entry of all these, entry or exit of these structures. Okay, so here we have the, what we need to remember is the surfactant substance is type 2 cells of the alveoli, right? The type 2 of the cells. So type 2 of the cells are going to give the surfactant substance. Surfactant substance is very important to decrease the tension of the surface of the alveoli. So when they close, they are going to be able to open again. If they are not present, the alveoli become closed. It's not going to be open. That's happening in premature babies, for example, right? Okay, so here we have what I want just you to remember is the names, and what we have here is the lung volumes, L. We have I, LI, inspiratory reserve volume. So all these lung volumes is all these. Volumes are the components, the summation of some of the volumes are going to give you capacities. Okay, capacities. So let's do volumes. Volumes, first of all, let's start with the tidal volume. Tidal volume is what you're breathing right now, in and out. You are not noticing, you are not thinking even you are breathing. So that air in and out is the tidal volume. How much is that? It's about 500 ml. 250 in, 250 out. So that is what you move every breathing. How much is the breathing? Between is 8 to 20 uh, uh, respirations per minute, right? All right, so anyhow, so here we have the tidal volume. That is your normal respiration right now. After you exhale, after you have at the end of the tidal volume, you have inspiratory volume. You're going to inhale all what you can, and actually it's going to be the inspiratory reserve volume. Then we have the expiratory reserve volume and the tidal volume again. So we have L-I-V-E-R, liver, 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 I of liver, V of liver, uh, E of liver, and R of liver, right? So those are the mnemonic you need to remember. We have inspiratory reserve volume, tidal volume, expiratory reserve volume, residual volume. Okay, so here we have how many? 1, 2, 3, 4. Again, 1, 2, 3, 4. Now, here we have, if we divide it in half, 2 here and 2 here, that means inspiratory reserve volume, and tidal volume is going to be the inspiratory capacity. And here we have 1 and 2, expiratory reserve volume is going to be the functional residual capacity. Functional residual capacity. Now, what is question here is the vital capacity. Vital capacity is going from here to here. So it's going to include the inspiratory, tidal volume, expiratory reserve volume. A way to remember this is the vital capacity. Vital capacity is everything but not the residual volume. Vital capacity is everything but not the residual volume. And what is the total lung capacity? Is everything, the 4 of them. All right, so that is about what I want to, one thing, hemoglobin plus oxygen. We have the carbaminohemoglobin, is the carbon dioxide with the what? With the hemoglobin. Regulation of the respiration is extremely important. Is the medulla. Medulla is medulla oblongata, especially the medulla oblongata. Part of the respiratory center is going to be located too in the pons, and some of them are going to be receptors. What I want to remember is the most important is the medulla. The medulla is going to have the crossover of the wiring of the brain. So the neurons are going to have crossover, passing from the right to the left, from the left to the right. That is the area where this is happening. And the medulla, in addition to that, they have the control, the respiratory center. Okay, adults 12 to 20, breathing patterns. Okay, all right, so that is about the review for this lecture. So let's go over the next one. All right, so let me see if I have some questions. Any question? All right, so let's keep going. Okay, so let's go over the disease and disease-producing organism. I'm going to highlight what we need to remember. Okay. So here, number one, we are going to see that. See what? Okay. So the first cause of death in United States is heart disease. Second are going to be, so first heart, second cancer, third start to be the chronic and lower respiratory diseases. It could be, mostly they end into pneumonias. All right, so we need to know that if the definition, what is the difference between inflammation and infection? You need please to remember what is the difference between incidence and prevalence. The incidences are the new cases in a year, prevalence are the new and the old cases. You need to remember what is acute, chronic, and subacute. Acute is generally is considered a disease that lasts less than 3 months. More than 3 months is going to be chronic. For example, pain. Chronic pain are going to be more than 3 months. Okay. What is pathology? A study of the disease. Subacute is in between. Subacute is acute is up to 3 months. Chronic is after 3 months. Subacute is considered between 2 to 3 months. So we can call subacute and acute still. So that is about. So the difference between signs and symptoms. Symptoms is subjective, signs objective. For example, pain is the most common symptom. Nauseous is another symptom. Signs, all the vital signs, temperature, heart rate, breathing respiration rate, respiratory rate, temperature, blood pressure. Syndrome is a group of signs and symptoms, and a disease is a group of syndromes. All right, so some bacteria that we just need to remember is about, let me see, sorry for coming back. All right, so portals of entry. So we must remember that how they are going to get into our body, the bacteria, viruses, skin, respiratory tract, digestive system, urinary and reproductive system. One thing that's coming to my mind at this moment is skin. So at the level of skin, you will see, for example, all what is outside of your body. So the skin, including, please, I want you to think the conjunctiva, the eyes. The eyes is a portal of entry to. So that's why you use goggles, because if you have some droplets or some substance like be infected with some bacterial virus, and this having contact with the conjunctiva of your eye, they can be actually entered into your system. So that's why we use goggles. Okay, so we have here coccus, Staphylococcus aureus. Can you see the coccus? These are purple. These are gram-positive Staphylococcus aureus, gram-positive coccus. We have streptococcus. Streptococcus is like a chain. It's going to be gram-positive blue, right, or purple. It's going to be positive bacteria. And this is the MRSA, this is the methicillin-resistant Staphylococcus aureus. So it's an Staphylococcus aureus that is resistant to some antibiotic that is called methicillin. All right, so here we have the gonococcus. Gonococcus is the gonococcal infection. This is happening in the long run. So first of all, the gonorrhea affects the genitalia, but if the patient is not treated for long period of time, they can produce arthritis, some infection around the articulations. Gonococcus, what color it is? Red or pink. That is what? Gram-negative, right? And here we have the Clostridium difficile. Clostridium difficile, this is a colonoscopy of the colon. You see this greenish area, that is the colonies of Clostridium difficile. Mostly happen after you have treatment with antibiotics or broad spectrum. Here we have the Clostridium difficile is blue, so that is gram-positive. And here we have the Pseudomonas. Pseudomonas are going to be gram-negative, red, right? Red. And here we have some bluish, greenish secretion that is Pseudomonas, mostly happening in diabetic patients. So that is the normal intestine. Can you see the difference we saw here? Look at this. This is the colonoscopy here in the arrow. That is abnormal. This is the but should be looking like that. That is normal. How different, right? Another picture of Clostridium difficile we have here. These are colonies of Clostridium difficile. What are these guys? Are gram positive. Gram positive. Okay, so here we have the coccus. We have, this is the E. coli. This is Bacillus anthracis. This is the anthrax. Anthrax. All right, so let's keep going with that. So I'm going to mention what I really want you to remember, and this is a review. Okay, so this is before meal, and this is after meal, eating blood from the patient that is actually ticks, right? And this actually can produce what we call different problems like Rocky Mountains spotted fever, for example. All right, so let's keep going. Let's keep moving. About malaria, just remember the malaria is going to have two cycles. One is in the liver and the other is in the blood. So in order to complete the cycle of the protozoarium, that is not like, can you see this green? Those are protozoariums called sporocytes. You don't care about that. So the protozoariums, this protozoarium or protozoa are going to enter into the liver, mature, get into the blood, and go back to the liver again. In that situation is going to repeat it, and they are going to destroy a lot of red blood cells. Can you see here? They are going to grow so many inside the red blood cells, they are going to be destroyed. And when they destroy, the fever start to appear. So we have, for future, you need to remember that malaria is going to have two phases, in the blood, and the other one is in the liver. All right, so we have some ascaris. Let's go over the lymphatic. So make a summary here. The lymphatic is going to have this, we have here the arteries, the veins, we have the arterioles, the capillaries, and the veins. So we have a connection between arteries and veins. But here in green, we have the lymphatics. These lymphatics are going to start individually in between the capillaries, and there is no direct connection between the arteries and veins or capillaries. There is no direct connection. And this, you see here, we have some, we have the layers of the lymphatic, outer, middle, inner, and the lymphatic vessel has what? Valves. All right, so here we have, I'm going to show you here. Here we have please, in the exam quizzes, I want you to be sure that the left lymphatic duct where it's going to drain, not in the left, in the right subclavian, it's going to drain into the left subclavian. The left subclavian duct drains into the left subclavian vein, and the right lymphatic duct drains into the right subclavian vein. Okay, so that is about the lymphatic nodes. What is the function of the lymphatics? The function of the lymphatics, number one, collection of excess of fluid. Number two, transport fats and some proteins. Number three, the transportation and formation of immune system, the lymphocytes. Okay, so we have the lymphoid organs are going to be the spleen, are going to be the thymus, are going to be the tonsils, are going to be we have lymphatic vessels on the or lymphatic nodes in the intestines wall. Other we have the appendix. Appendix is rich into lymphatic system, lymphatic vessel. You see the spleen, but paying your attention here. A spleen normally do not pass the inferior border of the rib. It's located in the what? In the left hypochondrium. Tonsils are part two. These are tonsils. Can you see the tonsil here? These are the part of the lymphatic. This is the uvula. Remember the uvula? Uvula is not a lymphatic organ, please, but I just want to mention uvula. What is the function of the uvula? The function of the uvula is when you swallow. So what is up there? When you go up there is the nasopharynx. So the uvula, what it's going to do is to, when the bolus is swallowed, this uvula help the bolus to not pass into the nasopharynx. So they are going to keep his way to the esophagus. We have edemas, and edemas you're going to see we have the lymphedema. Lymphedema is a no pitting edema. No pitting edema. Okay, so that is about this lecture. All right, so to remember here, we are going to see the next lecture is about body defenses, immunity, and vaccines. So here we have virulence. You need to remember that is part of that is the toxins, endotoxins and exotoxins. Exotoxins are the waste product of the bacteria. The bacteria eat, and what process and is going to get rid as a waste, that is called exotoxin. Okay, and endotoxin is a factor that is located in the membrane of the bacteria. And please, virulence is not related to virus. But virulence means how aggressive is the microorganism. Okay, so factors that involve infection. So how aggressive is the microbe? The predisposition to infection, individual conditions. So for example, just think about it. People who are very young, the immune system is not prepared yet. People who are very old, they don't have the proteins to produce enzymes to destroy the white cell, to be part of the enzymes of the white cells. So they are more prone to have infections, less defenses. People who are malnourished, they cannot have enough proteins to produce the enzymes because enzymes are proteins. Chemotherapy, patients with cancer. Patients with cancer, what they're doing is the chemotherapy is going to destroy bad cells and good cells, especially the red bone marrow, where you have the formation of the white cells and red blood cells. But in this case, immune system is the white cell related. Portal of entry. So where is coming from? Where is the entry of the microbe into your body? The skin, the GI tract, the urinary system, sexual contact, IV. So many ways. Dose is not the same to be infected by one bacteria than for 1 million bacteria, right? So it's easy for the body. The body can get rid of a few number of them, but not all of them. So the dose is an important factor to show infection. All right, so the first line, physical barriers. One example, skin, hair, nails, uh, tonsils. So second line of defense, we have the phagocyte cells, who are the neutrophils and the monocytes. And the monocytes transform into macrophages. Immunological surveillance are going to be the macrophage here, are going to be the lymphocytes, B, inflammation, interferon, complement, and fever, some part of the immunological reaction. So here we have how this is a cell, yellow is a portion of the cell. So the bacteria is going to appear as, I guess, here. This is the lysosome containing enzymes. So the cell is going to eat, phagocyte the bacteria, and the lysosome, that is an organelle, is going to destroy the bacteria. Okay? All right. So what is we have the yellow marrow and we have the red bone marrow. Red bone marrow, hematopoiesis. Don't forget, under hematopoiesis we have three things: the erythropoiesis, production of white cells, and the production of platelets. Inflammation, you need to remember the 5 cardinal signs of inflammation: pain, heat, swelling, redness, and loss of the function. Interferon is going to interfere, right? Interferon is interfering the activity of the virus, and that mostly make the virus able not to replicate anymore. Fever. Specific defenses, we have the lymphocyte B and the lymphocyte T. Lymphocytes B, we have, there can be two. Lymphocytes B, the lymphocyte B memory cells, and two, the lymphocyte B transform in plasmatic cells who transform into antibodies. Antibodies G, A, M, E, and D. And those are markers. So they're flagging or flag the bacteria in order to be recognized easily by the rest of the immune cells to know what to destroy. Okay, so the T cells, we have many types. We have the cytotoxic cells, that are cytotoxic cells that are the CD8. We have the helper T cells, are the CD4, regulatory suppressor cells, and the memory T cells. So we have 1, 2, 3, 4 type of T cells. All are important, but the one who is being hit by the HIV is the helper. The T helper is the commander who gives orders to the cytotoxic to give green light to kill the bacteria, and the memory cells to remember that memory cell, the bacteria, for future attacks. And regulatory suppressor is when the war is almost being won. The lymphocytes start to kill everybody, including normal cells. So it's coming the regulatory suppressor. Who gives the order? The T helper. Okay. So we have, all right, so body fluids. Okay, so this is a must. This is something that it should be knowing very, very much. We have intracellular fluid, extracellular fluid. Simple. Intracellular fluids is anything that is inside the cell. All fluid, sorry, the fluid that is inside the cell. Intercellular, extracellular fluids, everything that is outside. In the extracellular fluid, we have outside of cell the space between cells, that is the interstitial space, that is called what we have there, interstitial fluid. We have blood plasma, the blood is fluid, right? So the plasma is outside of the cell, so that's why it's extracellular. Lymphatic fluid, that is outside of the cell, so that is lymphatic fluid. And fluid in special compartments like CSF. All right, so this is what you need to remember, please. Major intracellular cation, potassium, major extracellular cation, sodium, major intracellular anion, phosphate, major extracellular anion, chloride. Okay, so the main organ who make the electrolyte balance is the kidney. The kidney. And the kidney is, you see the aldosterone that is produced by the adrenal gland. All right, adrenal gland produces aldosterone. What is the target organ? The kidney. Antidiuretic hormone, ADH. Who produces this? The pituitary gland. And what is the target organ? The kidney. So that is about fluids. When you're talking about, for example, the calcium, calcium is going to electrolyte balance. So this, we are not talking about kidneys only. So electrolyte balance is going to be the parathyroid gland who produce the PTH. PTH stimulate the osteoclast, and PTH appears only, and the parathyroid hormone, the parathyroid gland secrete only PTH only by the stimulus of low calcium in blood. Low calcium in blood stimulate the parathyroid gland, produce PTH. PTH stimulate the osteoclast. Osteoclast reabsorb the calcium from the bones, and the calcium goes to the blood to reestablish the 8.5 to 10 milligrams per deciliter of the levels of calcium. And the calcitonin is doing the opposite. Calcitonin is produced by the thyroid gland, produce calcitonin. So who stimulate the thyroid gland to produce calcitonin? The high levels of calcium, opposite of the previous example. So high levels of calcium is the stimulus who make the thyroid gland produce calcitonin. Calcitonin is released and stimulate the osteoblast. And the osteoblast take the excess of calcium from the blood and put it in the bone. Okay. So atrial natriuretic peptide, ANP, is from the heart, especially in the atriums. They are going to be released when you have too much blood volume. If you have too much blood volume, what happens? The atriums are going to distend. And that is a sign that produce the atrial natriuretic peptide that is going to make the eliminate fluids and decrease the tension against the atrium, so the blood pressure go down. Acid-base balance. So please, I don't have a pen here for the screen. So please, I want just you to remember this. pH, and please write down this. pH, blood 735 to 745. 735 to 745. Sodium, 135 to 145. Similar names, right? Similar numbers, right? Again, pH, blood 735, 745. Sodium, 135 to 145. So that is the sodium. Then we have the potassium. Potassium levels in blood is 3.5 to 5. 3.5 to 5. Now, in addition to that, just to remember, the carbon dioxide is not electrolyte, but we are going to see this in ABGs. Carbon dioxide is 35, 35 up to 45. Easy number to remember. And the calcium, 8.5 to 10. Okay, so we are going to see that we have the metabolic acidosis. Metabolic acidosis is when the pH go down and the carbon dioxide go down. Example, infections, diabetic ketoacidosis. Another, metabolic alkalosis, metabolic alkalosis, pH up high and carbon dioxide up high. Example, vomiting. Respiratory acidosis. Acidosis pH low, respiratory, carbon dioxide, the CO2 go up, opposite, right? So that is the respiratory acidosis. We have COPD, asthma, emphysema, atelectasia, bronchiectasias, acute bronchitis, chronic bronchitis. And the other one is the respiratory alkalosis. Respiratory alkalosis, pH high, respiratory carbon dioxide down. So example is hyperventilation, panic attacks, anxiety. Okay, so that is about this lecture. Let's go to the next one. We have about half an hour. Hopefully we can finish on time. Any questions so far, please? Okay, so talking about digestive system, the three main functions of the digestive system is going to be digestion, absorption, and elimination. Digestion, absorption, and elimination. Okay. All right. So we have the accessory glands. We have salivary glands. They contain saliva, of course, and secrete water and amylase. Other accessory organs, we have the liver, the gallbladder, and the pancreas. We have 4 layers in the mucus. We have mucus, submucous, and smooth muscle, serous membrane. Listen, please. Smooth muscle, peristalsis, is contraction, right? And who make contraction of these smooth muscles are going to be the acetylcholine, the cholinergic effect, right? Acetylcholine. All right, so let's keep going. So we have the villi that is actually what trying to do is to increase the surface of absorption of the nutrients. The peritoneum, we already talked plenty about that. Okay, the stomach. In the stomach, we need to remember the parts of the stomach. We have here the lesser curvature. We have the greater curvature. Here we have the fundus. Here we have the body. Here we have the antrum. We have the pyloric area, and here's where it's ending the stomach. Here we have a narrowing area that is the pyloric sphincter. And they are going to pass into the duodenum. This duodenum is the first part of the small intestine. All right, so duodenum is a part of the small intestine that's most all the chemical digestion is going to occur. So here's in the duodenum where the chyme is coming, the bile is coming, and who else are the pancreatic juice. So all these together are going to produce the area where we have the major chemical reaction for digestion. Okay, we have the components of the intestine, ascending, transverse, descending, sigmoid colon on the left side. The appendix, this area is the cecum. Here we have, if you see here, here is going to be the intestine. It's not seen here. Here we see it. And here we have, remember the pyloric sphincter is in the stomach, between the stomach and duodenum. We have now the ileocecal valve. Ileon, jejunal in small intestine, right? And the cecal is the area of the ascending colon. So ileocecal valve. So this valve is to prevent the return of the remnants of the food from the large intestine to the small intestine. So one thing that we need to remember here is on the large intestine we have the flora. Flora, we have 400 different type of bacteria. They controlling each other, so they don't want anybody to multiply more than others. And these are always under control. And this is a good bacteria. Why? Because we receive from them vitamin K. vitamin K is going to participate in the secondary coagulation to form fibrin. So we need vitamin K for coagulation. So that's why babies, when they're born, they need to have a vitamin K injection because they don't have flora. They was totally isolated in the uterus. They didn't have contact with the outer environment. So they need to populate the intestine, and it's taking a few weeks, even months, in order to have a normal flora in these babies. So that's why they don't produce vitamin K. Risk for infection, for bleeding, and that's why they have an injection in the quadriceps, in the thigh, right? Okay, so we have salivary glands. We have three pairs. Parotid glands, that is the largest salivary gland, submandibular, and the sublingual. What they produce? Saliva, amylase, and water, right? So here we have, again, so please pay attention to this. This is the common bile duct that drains where? In the duodenum. What is this? The pancreatic duct. Where is going to drain? In the duodenum. So we have bile 1, pancreatic juice 2, and here is the stomach. The stomach is going to come with a chyme. So we have three substances: chyme, bile, and pancreatic juice. Don't forget never that. Okay, so we have the bile coming to produce. What is the function of the bile? The emulsification. And what is the function of the emulsification? Is to spread out the fat, to have major contact or more contact with the lipase that is coming from the pancreatic juice. And the reason for that is to digest better digestion. Okay? All right, so let's keep going. This is the duodenum. Pancreas enzymes. What is the pancreatic juice? Listen, the pancreatic juice have the lipase, protease, amylase, water, bicarbonate, and electrolytes. So you already know very well the lipase function is to digest fat. Protease digest proteins. Amylase digest carbohydrate. We have water, sodium chloride, potassium chloride, electrolyte, and what is important is the bicarbonate that is giving the alkalinity of the pancreatic juice. What is that is this portion is the exocrine function. Then we have the endocrine function here, that is the insulin and glucagon. Insulin, what it's doing is make the glucose enter into the cell. Please, they don't come in with glucose and insulin, everything inside. No, the insulin is going to, let's put it this way, open the door for the glucose. The insulin stay outside. The glucagon is doing the opposite of the insulin. If the insulin is going to bring inside the cell glucose, the glucagon is going to take glucose from inside the cell outside of the cell. Glucagon, when you are starving, they are going to release that, process. We have here the islets of Langerhans. We have the alpha, beta, and delta cells. Alpha, glucagon. Beta, insulin. Delta is going to be the somatostatin. And another ones that we don't want to see at this moment is the BIP. And we have one who make the gallbladder contract. When the gallbladder knows who's telling the gallbladder, okay, gallbladder release bile. So is an hormone, because an hormone is a substance produce communication between the structures, right? So hormones is going to dictate what you need to do. And this case is the cholecystokinin, is the CCK, that produce the gallbladder contraction, release more pancreatic juice, etc. So a few now that I'm not going to mention because it can be confusing at this moment. Bile functions cause emulsification, is made in the liver, bile is made in the liver and works in the duodenum. Duodenum is the small intestine, the beginning of the small intestine, right? All right, so water, saliva, water, saliva has water, and the water is going to react with some substance like carbohydrates. That is hydrolysis. So as I told you, if you put a cracker in the water, what is going to do? The cracker is going to dissolve, right? Apart, make apart. That is digestion. They're digesting what? Carbohydrates. That is what you're looking there is hydrolysis. All right, so let's keep going. Absorption is the movement, please, absorption is the movement of digested food, right? Pancreatic juice, gastric acid, everything in the food is digested. That is passing from the digestive system to the circulating fluid. So they are going to go to the veins. Remember the superior mesenteric vein, inferior mesenteric vein is the vein of return. That is going to collect all the nutrients into the portal vein going to the liver. We have absorption of vitamins and minerals. We have folic acid is the jejunum, and the vitamin B12, sorry, folic acid in the ileum, and the vitamin B12 in the jejunum. So remember, folic acid and vitamin B12 promote what? Cell division. So what's important about that? Red blood cells. If you don't have vitamin B12 or folic acid, you have low production of red blood cells. Translating this means anemia. All right, so we talk about the stomach. It's going to produce the ghrelin, and that is going to make you hungry. So the stomach is empty, ghrelin is going to be secreted. Lipids. Lipids are going to secrete the leptin and suppress hungry. So when you eat already, suppress hungry, that is the leptin. Okay, some pathology. The urinary system, we are going to talk about we have the kidneys, bilateral. Kidneys, you can live with one kidney, yes. Can you live with one lung? Yes. Can you live with one ovary? Yes. One testicle? Yes. Nephrons. Nephrons, we have 1 million each kidney. Nephrons, they have the function. What is the functional unit? The nephron. The nephron, if you see here, the nephron is going to have, first of all, what is the nephron? Nephron is the afferent here, and the efferent arteriola, efferent. These are coming from the renal arteries we saw in the previous slides. So they're branching, and smaller, giving the afferent that enters into a tuft of vessel, that is the glomerulus. These glomerulus have some openings that produce the filtration of fluid passing through the blood. If you have higher structure, bigger structures that are bigger than those openings in the capillary vessels, they will not pass. They are going to stay in blood. But if they are smaller, they are going to escape and filtrate into the proximal convolute tubule. Proximal, they are going to get then into the Henle's loop, and then the distal convolute tubule, distal, up to here. This is the nephron, up to here, period. This guy that you see here, that is the collecting duct. That is not part of the nephron, okay? That is not part of the nephron. So nephron is from this structure, the glomeruli, down to the distal convolute tubule. So if we have 1 million glomerular nephrons, how many collecting ducts we have? We have 1 million collecting ducts per kidney. And that collecting ducts are going to be organized here because the glomerular, can you see here? This representing the glomeruli, the nephron. Nephron are located mostly in the cortex. They are going to locate it in the cortex. And this portion, the collecting ducts, are going to be located here in the pyramid. So can you see these rays like lines here? These lines is because many of these are coming together. 1, 2, 3, 4, 5, 6. They're coming into the pyramid. And they are going to drain into the pelvic, renal pelvis to the ureter, and they go outside into the urinary bladder. Okay, so the urinary bladder. So please, I probably need to remark a little bit more about, oh, certainly, we have the running here. So okay, let's keep going. The ureters are going to be ducts that are communicating the kidney with the urinary bladder. If you cut the ureter in half and see what is inside, you have that we have three layers again, similar as a vessel, but it's not a vessel, it's carrying urine, right? And the middle layer is a smooth muscle. A smooth muscle is being prone to be contracted. Who contract that? The cholinergic effect. Acetylcholine, giant cat, remember. So this is a smooth muscle and this obey and that's similar thing. So the ureter start to have peristalsis. When you have fluid, the ureter start to contract and help the fluid going towards the urinary bladder. So the urinary bladder now, here can you see the thickness of the wall of the urinary bladder? That is a smooth muscle. That smooth muscle is going to be contracted by acetylcholine, 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 acetylcholine again. We have the trigon. The trigon is, if you see the ureters are not coming here or here in the top, they're going posterior and below almost on the base of the urinary bladder, forming what we call a trigon. This is the entry and the entry of the ureter. Okay, remember the pH of the urine is 6. Bacteria hate urine, no, hate pH acid. So acidity, they hate acidity. Glycosuria is when you urine glucose. Urinary incontinence. Urinary incontinence. What is urinary incontinence? So let's make a small exercise here. You have urinary incontinence. Who make the, why is called incontinence? You cannot control your sphincters, right? You cannot control your urinary bladder. Urinary bladder is smooth muscle, involuntary. Cystitis, for example, inflammation of the urinary bladder stimulate the wall, stimulate the contraction of the urinary bladder. So what makes the contraction of the urinary bladder? The acetylcholine. Acetylcholine. So in this case, what is the treatment? For example, anticholinergic. So it's going to block the cholinergic effect. That is one of the applications, and that's why you need to remember about how important is the cholinergic effect. Cholinergic effect, contraction. Medications. Anticholinergic, the opposite of cholinergic, is going to block the cholinergic receptors, are going to do the prevent that contraction. Okay, so in this case, we are going to use anticholinergics. All right, so let's keep going to the next. Okay, talking about the male and the female reproductive system. All right, so we have sexual and asexual. You cut your finger, like we mentioned, cut your finger. So your cells are going to reproduce sexually or asexually. The is asexually, right? Or non-sexual. So all the cells of your body are going, if you've been destroyed, they're going to be replaced by asexual division. Asexual division. Or non-sexual division, right? The ones who divide in sexual division is going to be the spermatozoids and the ovules, period. Nothing else. Asexual or no sexual are going to be the somatic cells, and that is going to be through mitosis. And the sexual for meiosis. Meiosis, so they are going to have, we are going to see here the difference between meiosis and mitosis. Here, two daughter cells in mitosis with same chromosomal diploid. And meiosis, we have mother cell with four daughter cells that are going to produce haploid cells. N, 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 N. N means 23. Okay, so for example, the ovum in the follicle, they're going to produce meiosis. Meantime, the ovum is going to be released to be released by the ovary. Inside, they are going to be divided in 4, but only produce 1 because the 3 ones, these 3, are going to be reabsorbed. They're going to just decay. They are not going to continue. All right, so here we have the scrotum, and talking about the scrotum, we are going to have a picture here just to make a review. Again, this is not a class, this is a review. Here we have the seminifero tubules, seminifero tubules. Look at this. What is inside? We have the spermatozoid, spermatozoid, and they go travel into the epididymis. This is not epididymis. Epididymis is this, epididymis. Epididymis is where they're going to get mature. Then they go to the vas deferens. The spermatozoid, the head of the spermatozoid, we have the acrosome. Acrosome are, here inside we have the X chromosome, or we have the Y chromosome. In ovules, we have always X. But in spermatozoid, they can be X or it could be Y. Okay? So now that is the head of the, in the tip, we have some enzymes. This enzyme, when they make touchdown on the ovum, this is going to open, release enzymes to make a drilling directly over the membrane. And that is going to make the DNA pass into the cytoplasma of the ovum. Okay, so we'll be talking about epididymis. Let's talk about the highlight here. Let me see. Okay, so here we have, this is the urinary bladder here. This is the urethra. The urethra, vesical urethra go here. This is the urethra. All this. Urethra, 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 urethra. And here we have the vas deferens, seminal vesicles, and they are going to form the ejaculatory duct. So from here is where is coming the semen. And they are going to join the urethra. This is the urethra again, urethra. And the semen is going to join the, is going to be in the urethra and going out of the body. Okay, so we have the inguinal canal, and the inguinal canal we have inside the spermatic cord. What is in the spermatic cord? We have the testicular artery, testicular vein. We have the vas deferens. That is the communication between the inside, outside, right? So the spermatozoids are forming outside the body. They're coming into the vas deferens and go all the way in. Okay. All right. So one thing here, we have the inguinal canal. The scrotum or scrotal sac is keeping the testicles outside of the body to keep the temperature down 1 Celsius. Here we have the spermatic cord, very nice. This channel, can you see here, is the inguinal canal. Here we have the pampiniform plexus. This pampiniform plexus is nothing else, this blue, nothing else as the testicular vein. Testicular vein is the pampiniform plexus. Okay, so here we have again a close-up. Seminal vesicles, 60%, and fructose, keywords. Prostate, 30% of the semen. Alkaline, keywords. Okay. Cryptorchidism. Cryptorchidism, let me see if I have a picture here. No, cryptorchidism is when the testicles are not descended yet. So you can wait up to 1 year after you're born. If after 1 year it doesn't be in place, that testicle is not working anymore. Talking about ovaries, the ovaries are talking about female reproductive system. We divide the uterus in, we are going to divide in the fundus, best place for implantation, the body, and the cervix. We have three divisions, right? Three portions. Then we have the layers. The inner layer, the endometrium, the middle layer, the myometrium, and the outer layer is the perimetrium. Okay, so here we have the cervix. We have, this is the vaginal canal. We have the fallopian tubes. And we are going to divide the female reproductive system into uterus and adnexa. Adnexa, A-D-N-E-X-A, if you want to me to spell it. Adnexa. Adnexa is fallopian tube plus ovary, period. So what is the female reproductive system division? Parts, sorry, uterus and annexa. What is annexa? Ovaries and fallopian tube. Okay, so we have the FSH. The FSH stimulates the formation of follicles. You see here follicles. The formation of follicles, there's 1, 2, 3, 4, 5, 6, there are 10 of them. They are going to proliferate, but one of them are going to get bigger than other ones. And the 10 remnants, they are going to be reabsorbed. So they are going to keep growing, growing, growing. Can you see the ovum? Ovum is almost is the same size, same size. So the ovum is not changing. What is changing is what is around the ovum, that are the follicular cells. Follicular cells, these what I'm pointing here are the ones who produce estrogens. The estrogens are not here, okay? The estrogens are going to be absorbed by the arteries and veins, for the arteries, for the veins, sorry, and they are going to just go into the systemic circulation. Then when this is going to be making pressure, can you see the bulging on the ovary? They are going to be pressure, and like the pimple, they're going out. They're coming out. So these remnants of the follicular cells are going to form the corpus luteum. And the corpus luteum is producing progesterone that make deposit of glycogen in the endometrium in case they become pregnant. If they are not pregnant, the corpus luteum are going to be turning into corpus albicans. Corpus albicans are going to be a scar at the end. The corpus albicans, the corpus luteus is going to last 12 weeks, producing progesterone for the deposit of glycogen and nutrition of the embryo. Why 12 weeks? Because at 12 weeks, the placenta is taking over. The placenta, 12 weeks of gestation is where it's going to be completely formed and produce a lot more of progesterone. Here we have the fallopian tube, we have the fimbria, the infundibulum. Please, the fimbria is not different from infundibulum is all this. Part of the infundibulum is the fimbria. We have the ampulla, the isthmus, and the interstitium. That is the, can you see, this is the endometrium, endometrium, the wall of the uterus, myometrium, and this is the entry of the fallopian tube. So where is going to be the fertilization? In the ampulla. The fertilization is happening after 1 day of the ejaculation. And when happen the implantation, the implantation happened in the endometrium. That happened 6 days after the encounter of the sperm and the ovum. 6 days after fertilization. Okay, so let's keep going. For genetics, I'm going to remark few things that this is mostly a review, as we already mentioned, and definitely I'm highlighting what is really relevant for us. So for this, I would like just to finish with some pathology. Okay, sickle cell disease. Mostly what happening is the shape of the red blood cells is going to be this changed because of the lack of protein in the cell membrane of the red blood cells. So make the red blood cell more fragile. That is an autosomal recessive. So the class for this topic is to divide the have somatic genital genetic disorders, somatic. So let's go here for just a moment. I'm going to go over, this is a karyotype, look at this karyotype. This is a karyotype, 46 chromosomes. So these are the somatic. So from 1 to 22 are somatic. And the 23rd pair, we have 44 so far here, 45 and 46. The pairs are going to be sexual. So pathologies are related to some diseases, not all diseases are related to the chromosome, the somatic, those are somatic genetic disorders. And the ones who are related to abnormalities of the sexual chromosome are sexual X-related chromosomal disorders, congenital disorders. All right, so we have autosomal recessive. Recessive, you need father and mother to have the gene. Dominant, or the father or the mother is enough to transmit the gene and produce the disease. Sickle cell disease is autosomal recessive. Down syndrome is an autosomal, is a disjunction of the chromosome. You have an extra chromosome 21. Neurofibromatosis is the autosomal dominant. It's important to know, and that I make those explanations because you need to always remember Tay-Sachs disease. Ashkenazi Jewish descendants. Okay, so that is an autosomal recessive. Mental retardation, live between 11 to 13 years. And this is mostly the population affected. Cystic fibrosis is an AR, again, is an autosomal recessive, and that is produce an increase of the thickening of the mucus, producing infections. Infections in the gallbladder, in the respiratory tract, number one, pneumonias. Infections in the gallbladder, cholecystitis. Infections on the pancreatic juice, because they cannot flow, get infected, pancreatitis. Okay, so for X-linked disorders, we have the color blindness, we have the Klinefelter, Turner syndrome. Okay, so X-linked here we have color blindness is compensated by the other X. Klinefelter is going to be a male, but with no appearance, but some characteristic of female because they have XXY. Turner syndrome, we have X0, so there's no more X to compensate. There's no. So what happened is going to be giving this Turner syndrome that is low stature, low IQ. Hemophilia is going to be a recessive condition, mostly is going to pass to males, males, and they are the lack of a gene that produces one of the coagulation factors in the liver. Okay. So thank you, everybody. So I think we finished our review. So I'm going to make some microphones out. So please,
Finally.
Cindy, thank you so much. Thank you, everybody. B,
Thank you,
Sarah, San Juana, Samantha, Saida, thank you so much. Rose, Nita. All right, so thank you, everybody. So I hope if there is any question, please. Everything was okay, clear, or help, or you want me to repeat something?
Mm, Thank you, Dr. G.
All right, thank you so much, everybody. So
Thank you,
have
Dr.
a
G.
nice weekend. I will see you Monday at 10 o'clock and 5 and 6 o'clock. 6 o'clock.
Thank you. Have a good night.
Have a good night. Thank you, Harjit. I hear you.
Good night, everybody.
Bye-bye. See.
Good night.
Good night.
Bye.
Okay.
Jerry, have a good night. Take care. Thank you.
Thank you, Dr. G.
Oh, by the way, for everybody, I'm going to post it in the, this is going to take about 1 hour to post it. So I'm going to send an email to everybody so you can find me in my channel. Thank you so much. Have a good night.